Hello everyone, welcome to Samson's Medlin Academy. So today we are going to discuss DHA exam recent questions and answers. So myself, I am Swathy Samban. I am a DHA qualified clinical pharmacist from Samson's. So I cleared my exams on 3rd of June 2025. So this is my scorecard. So for pharmacist and for clinical pharmacist, we have the same syllabus and the same questions. The only difference is that in pharmacist exam, you should score above 60 percentage to qualify the exam. And for clinical pharmacist, you need to score above 70 percentage. So that's the difference between pharmacist and clinical pharmacist. It's just the marks cutoff difference. The rest is the same. Okay, so let's move on with our first question. So our first question is a patient with severe obesity, and this patient develops a pulmonary embolism and is treated with enoxaparin. So which laboratory test will best help to monitor how well the enoxaparin is working? And we are given four options. The first option is APTT, which is the activated partial thromboplastin time. Option B is anti-factor 10A. Option C is the INR. And option D is the platelet count. So from the question, we understood the patient is severely obese and there is a pulmonary embolism emergency. The clot has reached the lungs and is treated with enoxaparin, which is a low molecular weight heparin. So which laboratory parameter can we use to monitor the enoxaparin? So from the options, some options we can directly exclude them. We can say it's not the answer. So definitely it's not platelet count or enoxaparin is an anticoagulant and we are not going to rely on platelet count. We have option C, INR, which is used to look into the clotting time. It's not INR. Now the options left is APTT and the anti-factor 10A. So we know for heparin, we use APTT for monitoring. So what is it when it comes to enoxaparin? For enoxaparin, the right answer is anti-factor 10A. Option B is the right answer. So let's look into the explanation. So in heparin works by enhancing the activity of antithrombin 3. So this antithrombin 3, it inactivates both thrombin, that is factor 2A, and factor 10A. So APTT is typically used to monitor unfractionated heparin therapy. That's clear. So coming to enoxaparin, enoxaparin is a low molecular weight heparin. So when we look into the mechanism of action, we can understand that enoxaparin predominantly inhibits a factor 10 rather than thrombin. So APTT is the test of choice for unfractionated heparin and anti-factor 10A assay is preferred for monitoring enoxaparin due to its mechanism of action. So our answer is anti-factor 10A. Hope it's clear. Moving on with the next question. So now we have a case scenario. So in this case scenario, a 26-year-old patient is admitted to the ICU and the patient is diagnosed of meningitis. Intravenous vancomycin and ceftriaxone were started. The patient's vancomycin trough levels is reported as 10 mg per liter. And the creatinine clearance of the patient is given. It is given as 120 ml per minute. And what would be the most appropriate recommendation for managing his vancomycin therapy? So option A is to keep the vancomycin dose the same. Option B is to increase the vancomycin dose. Option C is to decrease the vancomycin dose. And option D is to discontinue vancomycin. So from the question, we understood the patient is having a serious condition, meningitis, and the drug of choice for meningitis, which is the IV intravenous vancomycin and ceftriaxone were started. And the patient's vancomycin trough levels came as 10 mg per liter. We know that vancomycin is related to nephrotoxicity as an area. So they have also given us a creatinine clearance, which is 120 ml per minute. So the creatinine clearance is normal. So looking into the trough levels, what can we choose from the options? So the right answer to this question is to increase the vancomycin dose. So I'll explain the reason for that. So for vancomycin, we ideally send the trough levels. keep in mind, it's not the peak levels. We consider the trough levels for vancomycin. So when do we take the trough levels? After the third dose, before the fourth dose. That is, ideally speaking, about 30 minutes before the fourth dose to ensure that the steady state is reached. So after reaching the steady state, before giving the fourth dose, 30 minutes before that, the blood samples are drawn from the patient. And that blood sample is used to look at the levels of vancomycin. So for severe infections like meningitis, the recommended vancomycin trough level concentration is 15 to 20 mg per liter. Okay, so after giving the trough levels of the patient, looking into the lab reports, we need to make sure for serious infection, the level should be between 15 to 20 mg per liter. So in this patient, in this case scenario, the patient trough level is 10 mg per liter. So what can we conclude from that? So it is actually below the target range. So ideally, we need to increase the dose of vancomycin. So also one more thing was given, his renal clearance is normal. So that we can definitely go with the option to increase the dose of the vancomycin. So it's option D, to increase the vancomycin dose. Hope it's clear. So the next question is, a 32-year-old patient is being treated for mild skin infection with intravenous vancomycin. What is the recommended trough concentration range for vancomycin in mild infection? We have got four options. Again, it's vancomycin, and the four options are: option A is 5 to 10 mg per liter, option B is 10 to 15 mg per liter, option C is 15 to 20 mg per liter, option D is 20 to 25 mg per liter. From the previous question, we know that for the severe infection, we need to maintain the trough levels between 15 to 20 mg per liter. And in this case, it is mentioned it is a mild skin infection. So for mild skin infection, the right answer is option B, that is between 10 to 15 mg per liter. Let's see the explanation. For mild to moderate infections such as skin and soft tissue infection, the vancomycin trough level should be kept within 10 to 15 mg per liter. So we know that this range is effective and it also minimizes the risk for any nephrotoxicity or any other side effects from happening. So we need to understand higher trough levels, that is 15 to 20, are actually reserved for infections such as meningitis or pneumonia or endocarditis. Then the range will be between 15 to 20 mg per liter. But for mild infection, the range can be between 10 to 15 mg per liter. Okay, so hope that it's clear. And let's see what's the next questions. So here, which of the following medication is commonly associated with red man's syndrome when administered rapidly? We are given four options. Option A is ceftriaxone, option B is amikacin, option C is vancomycin, and option D is metronidazole. So red man syndrome, always remember it's option C, it's vancomycin. I've actually clubbed the vancomycin questions together so that you have an understanding. Just with one drug, these are the number of questions that you can expect. So vancomycin is important, and red man syndrome is the answer is the one related to vancomycin. So vancomycin can cause red man syndrome when it is administered rapidly. Okay, let's see the explanation. So red man syndrome means is an infusion related reaction. It is characterized by flushing and rash, and sometimes hypotension can also happen. So I have included an image. So this is a patient who has developed red man syndrome when they have administered vancomycin. So it is most frequently occurs when this IV vancomycin is rapidly administered to the patient. So this can actually be avoided, like you need to slow the vancomycin infusion rate, and even pre-medicating with antihistamines can actually stop from this syndrome happening. Remember, whenever you see red man syndrome, it's vancomycin related ADR. Okay. So let's move on to the next question. The next question is, which type of research study offers the most credible evidence for guiding a clinical decision? We have option A as case reports, option B as cohort study, option C as systematic review, option D as cross-sectional study. You can expect questions from these areas. You need to have an understanding what each of these terms are. Only then you can answer these questions. So let's see. According to this question, the question they are asking us is, what will be the most credible evidence? What will be the best evidence from this for guiding a clinical decision? So let's see what each of these terms mean. So the first one is a case report. So a case report actually describes the clinical details of a single patient. It provides a low level of evidence. So what do you mean by clinical details of a single patient? A medical practitioner is seeing a rare case. So then this medical practitioner will report this. That is basically a case report. So inside that case report, it will only be having details of a single patient. So that is actually considered as a low level of evidence. So next comes the cohort study. So in cohort study, what do? We follow a group over a time to assess the relationship between the exposure and outcome. So we all know that classic example. A group of people are looked upon over a time. Like we'll say this example, we have smokers and we have non-smokers. So we'll observe them over a time to see how many of them will be developing lung cancers. So how many of them after smoking developed lung cancer and how many non-smokers developed lung cancer. So this is kind of a moderate evidence. Okay. So cohort study gives us moderate evidence. So next comes the systematic review. So what does a systematic review mean? It summarizes data from multiple studies and offers the highest level of reliable evidence. So in this, I'll explain systematic review in simple terms. So one person from South India is doing a clinical trial in South Indian population, and another investigator is doing it in North India, a similar clinical trial. So someone else is doing this in South Africa, someone else is doing this in America. So the thing is, all of them will be having different populations in their clinical trial. So some of them will be studying in healthy adults, some will be studying in children, some will be studying in geriatric population, some will be studying it in pregnant groups, and all of this data are there in each of this investigators, and they have published these data. So there will be one independent person, one reviewer. What this reviewer will do is, on a particular topic, this person will collect the maximum amount of trials that has been done around the world. And this person will go through each of the studies, and then this person will summarize. So it is like you need not read 100 papers to come into an answer. You have to just read a systematic review. So this systematic review will summarize the data from multiple studies, and this is like a high level of reliable evidence. So that is there. That can be the possible option, but we have one more option left, which is the cross-sectional survey. So this cross-sectional survey, what it does is it evaluates data from a population at a particular point of time. So we go into a population at a point of time, collect all relevant data and come out. So it happens only at a point of time. So this is also good evidence, but not as good as a systematic review. So now what do you think the answer is? The answer is option C, which is systematic review. This pyramid will help you get a more clearer idea of this. So at the base of the pyramid, you can see editorials and expert opinion, which are like low levels of evidences. So as you go up in the pyramid, you can see case reports. Above that, you can see cross-sectional studies. Above that, you can see case control studies. Above that, you can see cohort studies. Then you have the randomized controlled trials. And above that, at the peak, you can see systematic reviews and meta-analysis from all these clinical trials, all these randomized controlled clinical trials. People can write systematic review and meta-analysis. So whenever you see systematic review or meta-analysis, you need to understand they are like the top quality of evidences. So systematic reviews analyze multiple high quality studies on a particular topic and provide a comprehensive summary of the best available evidence, making them the most reliable source of clinical guidance. Okay, hope the answer is clear. Let's move on to the next question. So here, the question is, healthcare staff wearing masks during pandemics such as COVID-19 may make communication with patients harder. Which of the following will enhance effective verbal communication in this situation? Very simple question, and we have got four options. The option A is eye movement, option B is gestures only, option C is the tone of the voice, and option D is the written information. So in such questions, the questions and the option seems very simple. The thing is, you need to go properly through the question and you need to make sure how easy the question is. You need to go through each of the options and read complete options. Only then come to a conclusion. Because you read the question, you see any option and you think that's the right answer. Always remember, there must be a better answer. Okay, so you need to go through each of the question and each of the options and read the question thoroughly. Suppose in this case, this was one of the questions that I got for my DHA exam. You look at the option D, written information. You might feel, okay, that is the right answer. The patient to communicate, you are wearing a mask. Why don't you just write and show it to the patient? That's an easy way. But see, in the question, they have clearly mentioned which of the following will enhance effective verbal communication in this situation. And the right answer to this question is option C, the tone of voice. Okay. So, with facial expressions partially hidden, careful attention to the tone, clarity, and volume of the speech becomes crucial for effective verbal interactions with the patient. So the question may seem simple, it's actually simple, but make sure that you read the options, you take the time to read the options and conclude in the right answer. So hope this is clear. Moving on with the next question. Isotretinoin, a drug of choice for acne, falls under which pregnancy risk category? Option A is B, option B is C, option C is D category, and option D is the X category. You need to make sure that you are thorough with the pregnancy risk categories, which all drugs falls under which all categories. Suppose in this question, like it's isotretinoin, they have also mentioned is it's a drug used for acne. So at times, as pharmacists, we can encounter such prescriptions in the pharmacies. So we need to make sure if it is safe in pregnancy or not. So the answer to this question is option D, which is pregnancy category X. So isotretinoin is classified as pregnancy category X. That is, it carries a significant risk of causing serious birth defects and should never be used during pregnancy. As pharmacists, we need to know that when we are dispensing each of our medications, we need to make sure which category our drugs fall into. And see, this drug may seem like a simple one for acne, but it poses very serious risk in pregnant patients. So this is the answer to this question. So isotretinoin falls in pregnancy category X. So let's move on with the next question. Here we have a 52-year-old patient who has been newly diagnosed with diabetes. So in the history, when we look into the history of the patient, it reveals that he develops hives, which is allergic reactions, when taking trimethoprim sulfamethoxazole. So which one of the following anti-hyperglycemic medication should be avoided in this patient due to his allergy? Should be avoided, okay? Due to his allergy history, he is allergic to trimethoprim, sulfamethoxazole, which is our cotrimoxazole. So we need to understand the chemistry in this drug. So our trimethoprim, sulfamethoxazole has the chemical structure sulfur in that. So we need to look among the options. We have four anti-hyperglycemic medication. Option A is the metformin, option B sitagliptin, option C is the glipizide, and option D is insulin. So the right answer is option C, glipizide. So glipizide actually belongs to sulfonylureas class of oral antidiabetic drugs. So the sulfonylureas like glipizide contains sulfonamides, which is the sulfur chemical structure. So the sulfur chemical structure is similar to sulfonamide antibiotic, which is the trimethoprim sulfamethoxazole. So therefore, glipizide and other sulfonylureas are generally avoided in patients with documented sulfonamide allergy. So in our patients, if we are seeing that the patient is having an history of sulfur drug allergies, we need to be careful that we are not dispensing any similar structural drugs to that patient. And you need to have an understanding of the sulfur containing drugs. You need to be familiar with this. There are a few that I've listed here, like which all antibiotics are containing sulfonamide. We have sulfamethoxazole, sulfadiazine, and we have drugs that we use for inflammatory bowel diseases and rheumatoid arthritis, like the sulfasalazine. We have the sulfonylureas, that is the oral antidiabetic, like the one we discussed, which is the glipizide. We have diuretics, which is the thiazide diuretic and the loop diuretic. In thiazide diuretic, we have the hydrochlorothiazide. In loop diuretics, we have the furosemide, and there is acetazolamide, celecoxib, Dabson, which we use in leprosy and skin conditions, the sulfadiazine, which we use for topical burns, probenecid. So we need to have an understanding of the sulfur-containing drugs so that we don't dispense these to a patient who is having a sulfur allergy. So the next question is, what is the recommended preventive measure for avoiding influenza infection? So this is also a seemingly simple question. What is the recommended preventive measure for avoiding influenza infection? Option A is antibiotics given annually. Option B is the vitamin supplements. Option C is yearly flu vaccination. Option D is the herbal therapy. So from these options, influenza, viral infection, definitely not option A. Antibiotics cannot be given for any viral infection. That option completely we can avoid. Next, we have vitamin supplements. Yes, vitamin supplements will improve our immunity and helps us to prevent infections. But should we go with vitamin supplements? No, we need to look into the full options. We need to go through each of the options. We have option C is the yearly flu vaccines, and option D is herbal therapy. So in this, you might get confused. I'm just clarifying that usually we take vaccines like once, or like there will be three scheduled vaccination schedules will be there. And like in COVID pandemic, we had one dose and the booster dose. You might think yearly flu vaccinations. Yes, even though it's not very popular in India, Western countries, they have a yearly flu vaccination system. So the answer, the right option to this question is the recommended preventive measure for influenza is option C, which is the yearly flu vaccination. So in other countries, they take the yearly influenza shots. All of the population, the people get the shots to prevent them from the flu seasons. So annual vaccination is the best evidence approach to preventing influenza. So that's the right answer. So let's move on with the next question. Simple question. What is the antidote used in managing heparin overdose? We have option A, vitamin K, option B, activated charcoal, option C is the protamine sulfate, and option D is fresh frozen plasma. We know that the right answer is protamine sulfate. So protamine sulfate directly binds to heparin, neutralizing its anticoagulant effect. So it is an specific antidote for heparin therapy, heparin toxicity, whereas vitamin K is an antidote for warfarin. And we know that our activated charcoal binds to toxins in the gut. So here the answer is protamine sulfate is for heparin toxicity and vitamin K is the antidote for warfarin. So hope that it's clear. So thank you everyone for listening. Thank you.